Hi everyone, and welcome to our final workshop in our series on transforming health services in line with the government priorities. Before we start, I'd like to introduce ourselves. We are Unity Insights, a social enterprise embedded in the NHS, having historically been part of one of the health innovation networks. We have a vast experience of working with healthcare professionals, innovators, and commissioners to support with NHS-specific challenges. I'm also sure you're wondering who we are and our roles at Unity Insights, so I will first pass on to Ben, who will introduce himself.
Thank you, Faye. So I'm Ben Williams. I'm a senior analyst at Unity Insights. I'm one of the old guard. I've been with the organisation since 2015. Currently, I'm leading on a range of different evaluations, one of which you'll find out more about shortly.
Thanks, Ben. My name is Faye Maddock. I'm a senior analyst at Unity Insights. I've been with the team for just over 3 years now, and whilst being part of the team, I've used various analytical techniques in a wide range of projects spanning from evaluating apps aiming to improve operational efficiency to radiotherapy treatments for cancer. Today's focus is on ensuring patient safety. We'll go through the challenges related to this topic and how the government and NHS priorities aim to alleviate these issues. We'll then cover the importance of quality improvement and embedding change with a couple of examples before sharing with you our learnings from the workshop. We'll also take any questions in a Q&A session at the end, so please use the Q&A function if you do have any questions. First of all, let's start by going over the challenges faced and the ambitions set by the government and the NHS. Many services in the NHS are described as challenged and fragile in this year's planning and operating guidance, suggesting significant risks to safety. Despite this, there are also risks that safety may have to compete with other objectives on the agenda for change, such as financial budgets. Resources are constrained. This is nothing new for the NHS, but government has announced that it's seeking cost savings of 1% and productivity increases amounting to 4%. Difficult conversations will likely be held, but the inevitable disruption and reorganisation just creates risks for service quality and safety, and it also risks delaying the implementation of safety initiatives. Innovative survey and service and pathway redesigns have been seen in the past few years, and they are expected to continue. Some examples of this are the shift towards integrated care, scaling up digital technologies, and the self-care model. The technological revolution is very much on our doorstep with the era of AI, and there are, of course, big opportunities to improve safety in terms of technological innovation, but there's also significant risks. Implementing change must be executed with great care and understanding of such changes to ensure that these risks are mitigated and opportunities are realised. Inequalities and trust are two issues that loom large on the current landscape, particularly in maternity and neonatal services. Recent reports on the status of maternity care have been widely publicised, and investigations continue, damaging confidence and trust in service provision. These events have also highlighted the inequalities associated with service delivery, with unsafe services being a key driver. Trust, which in many cases must be strengthened or rebuilt, is key to ensuring that patients and services can work together to improve care. Safety was only briefly mentioned in the operating guidance for this year, with the only success measure being around maternity and neonatal services. There doesn't appear to be a standardised approach to patient safety, highlighting the need for standardised approaches to be set out and for safety to have more importance. The government have also pushed back on the CQC, suggesting that it wasn't fit for purpose, and this national lack of approach leaves local systems to define their own priorities. The inevitable invariability at the local level will require significant intelligence gathering and also monitoring to see needs identification through to delivery. The 3-year delivery plan for maternity and neonatal services is informative, but data and digitalisation are notoriously challenging to get right. And as always, there will be variation in how the changes are delivered and implemented across the country. But this also means that there will be many opportunities for learning and improvement across the country. Given the uncertainty and the variation that we expect to see in patient safety in the coming year or two, measurement and therefore data will be key to supporting delivery, maximising impact and creating efficiencies. Today, our focus will be on quality improvement and evaluation, although we will focus on some alternative methods to the business as usual approaches as well. Quality improvement involves continuous measurements of service design and delivery to continuously improve a service. The NHS typically use Plan, Do, Study, Act, or PDSA cycles, which test changes on a small scale before implementing at a wider scale. This helps us to understand whether change has been effective, whether a service meets operating standards, and what areas require further improvements. We tend to conduct evaluations to understand the impact of a service change, and this helps us to collect insights into what happened and why. Evaluations are typically conducted towards the end of a project, but prospective and interim evaluations can also provide good value. Evaluation helps us to understand which projects are worth developing further, how we can realise the largest impact, and what factors affect whether an intervention is effective. So we are going to go into some examples of the ways that we've used evaluation to support service improvement in the NHS. Our first case study looks at the Real Birth Workshop. This is an online workshop consisting of 11 modules focused on elements such as the different stages of labour and how the uterus works during labour. These modules can be completed in the user's own time, and the use of modules allows women to learn in a structured approach. The Real Birth Workshop aims to be accessible through allowing women to select their preferred language and change the background colour, text size, etc. So the aim here is to ensure that as many women as possible have access to birth preparation information. The workshop was implemented in 2 hospitals in East Kent Hospital's University NHS Foundation Trust. Here, staff were to be trained to understand the information that the workshop provided and ensure that they were comfortable with referring mothers to the workshop. We were commissioned by Health Innovation Kent Surrey Sussex and the Real Birth Company to evaluate the impact of the workshop and the staff training to provide the workshop within East Kent Trust. In our evaluation, we compared the ethnicity breakdown from the proportion of antenatal patients in East Kent Trust overall to the proportion of patients who completed the Real Birth Workshop. And this chart here shows the findings. So we can see that the proportions vary between the 2 populations, and it makes us think what percentage counts as a significant difference between the 2 populations, and what percentage would count as these proportions being the same. So today we are going to focus on the Black population, for example, where you can see that 1.6% of the trust population are Black and 2.6% of the workshop population are Black. So we completed some statistical testing, and we understood that the proportion of Black patients completing the workshop was statistically significantly greater than the overall proportion of Black patients in East Kent Trust. And this suggests that the workshop mitigated health inequalities and it was actually more accessible to a disadvantaged population. If the workshop was not accessible to Black patients, this would then risk patient safety as these patients are not able to access care when they may require it. In this case, this could lead to reduced knowledge sharing, which may result in these patients having a more uncomfortable birth, which could then potentially lead to issues with safety. We also conducted qualitative analysis through use of surveys with staff and patients. Here we found that patients found the workshop useful in their labour and that they would recommend the workshop. Again, this highlights the importance of ensuring all patients who would benefit from the workshop have access to the workshop. Staff were able to offer more bespoke care to patients due to the workshop as well, which then means that they can likely provide better quality of care that suits their needs, therefore enhancing patient safety. Combining qualitative and quantitative analysis helps us to understand uptake levels and provide evidence for why an innovation works well. It helps us to understand what its benefits are to patients and staff and what the results of the benefits lead to. In this case, patients can learn more about the options available to them during their birth, and this allows them to make more informed decisions around their care, leading to hopefully a smoother and safer birth than if they were to go in without this knowledge. Staff can offer care that's more tailored to each patient's needs, further improving the quality of care provided and therefore potentially improving patient safety. Our next example focuses on Black maternity matters, which is an anti-racist training programme which is developed and delivered by people with lived experience to maternity staff. According to the Embrace reports, Black women are 4 times more likely to die during pregnancy or in the postnatal period than white women. Stillbirth rates of Black babies are also over twice those for white babies. It's hoped that anti-racist training can equip staff to recognise attitudes and structures that negatively impact Black mothers and their babies, as well as support quality improvement in this domain. We were commissioned alongside Health Innovation West of England to identify the impact of Black maternity matters on participants, to understand these learnings and inform further spread of the programme. And to do this, we use surveys and semi-structured interviews. We found that the feedback for the programme was overwhelmingly positive, with responses to the survey suggesting improvements across all questions asked following the programme. This highlighted a Dunning-Kruger effect in the pre-training surveys, where staff appeared to overestimate their knowledge. But overall, it was suggested that the course increased knowledge and also increased self-reflection. Conducting the evaluation meant that we received data from staff who completed the programme, giving us insight on the first-hand experience. We then used this data to understand whether the programme helped or hindered racism in the workforce. We were able to understand that staff had greater understanding of racism, which could then hopefully result in better, safer care for patients due to increased awareness. In turn, this has a positive impact on patient safety due to fostering a more inclusive and aware care environment. This highlights the importance of evaluation in identifying the impact of an innovation on patient safety. If we don't conduct evaluations, we don't know what impact something can have. So I'm going to pass on to Ben now, who will cover embedding change in the NHS.
Thank you very much, May. So I'm going to look at embedding change through the lens of analysis and evaluation. Now, whether you're implementing an innovative approach, introducing a new widget or software, or redesigning a pathway, you're introducing change. And a key element from patient safety is that if you introduce a change, you must measure that change. Now, clearly having an adequate evaluation will be beneficial with a summative report delivered at the end, and you'll learn what worked and what didn't. But can we do something a bit more interesting which will provide for better and more timely delivery of information? Now, when implementing a QI program, gathering real-time data can help the team to understand where to focus their precious time and limited resources to maximise potential impact. There's always a trade-off with data collection between the burden you place on the people and the system in collecting data and the value that data can provide. The trick is to collect enough data with enough regularity and turn the data around to provide useful information in a short enough time period to make all of that effort worthwhile. So this case study is a new evaluation we've only recently begun, and as such I can't tell you too much of the specifics, but the reason I wanted to use this is it's a great example of how we can apply QI principles to evaluation. So this software, it essentially transcribes the patient-clinician conversation and provides intelligent summaries in different formats, including summaries for adding to EHRs, patient letters, colleague and referral letters, and suggested clinical coding. The pilot will be purposely short, lasting just 13 weeks. This is considered long enough to assess both feasibility and to gather in data to inform future purchasing decisions. But with such a short window, the project team are keen to capture data regularly and have it fed into the steering group to inform any necessary change in direction. One part of the feedback loop I want to share today is the qualitative stream. So here, staff are asked to provide the following information via a Microsoft form each week. So we ask for their setting and their role for grouping purposes, and then we ask on a scale of 1 to 5, to what extent do they agree that this software, 1, saves them time, 2, facilitates better interactions, 3, is safe, and 4, is accurate. Finally, there's an optional field available to provide any free text feedback for additional context. From this short survey, which is expected to take around 90 seconds to complete, we can then develop a dashboard to give near real-time feedback. So based on requesting just this most basic of information, but doing so in a structured way and collecting data over time, we can then create some powerful visualizations which will immediately tell their own story. Now, this is dummy data, which I created to demonstrate a point, but were this to be true, and the sentiment seems mixed, or at least adoption is not high as expected. So what you can see in these charts, green is a positive sentiment, blue is neutral, pink is negative. So looking at this, I can see people feel it generally does save them time, and it does facilitate better interactions, but for some reason which the data doesn't tell us, feelings are equally spread around safety and mostly negative in terms of accuracy. This could imply that the technology works, that when the technology works is great, but maybe there's some sort of significant issue around accuracy, which then in some cases may impact safety. By collecting data from users each week, we can also look at how that sentiment changes over time. So now we can see that actually of the 4 elements scored, all 4 elements scored relatively low in the first week, but 3 out of 4 of them are now rising over time. So this is adding context. So we know that accuracy is the element which not only scores the lowest, but is also barely increasing over time. So now you can see we have a rich data set, and that can help inform the pilot as it continues. Now, this will not provide all the answers, but it will show you where to look, and it might also act as an early warning system for any emerging issues. Note that we also give people the option to provide the additional free text feedback, and this is vital to any evaluation because of the limitations of the quantitative analysis. A separate analysis of that free text data will give further context and may help explain why it is, for example, that efficiency in communications are still being felt despite the accuracy being considered low. So the example we discussed involved deployment of a new software, but this approach could be used in any situation where you're introducing change. So this could be a new respiratory pathway in primary care, which allows for the testing for flu, COVID, RSV, or other respiratory viruses in the community. It could be used in introducing a new care bundle for high-risk emergency surgery patients. or it could be deployed when introducing a new orthopaedic pathway in which patients with suspected hip fracture bypass A&E and instead go immediately to orthopaedic department for triage and management. In each situation, the questions will necessarily differ, but adopting this approach can provide you and your project teams with invaluable information in near real time, and when interpreted correctly, can provide actionable intelligence to help drive the project forwards. Specifically, if you're running PDSA cycles, you could deploy a questionnaire at the end of each do section to collect data for the study element. The results from each cycle can then be compared to create a more comprehensive view of which aspects and changes were the most effective. If it's a QI program, you could deploy it throughout over time or until stability is achieved in order to measure that change. The importance of providing contemporaneous data remains the same. You saw in the examples how we can create powerful visualizations, and I also mentioned the reasons that some of that sentiment shown is unknown. So regardless of what you're measuring, a single metric will not give you the answer, and as you saw, neither will four. If you have the budget and the project is planned to last at least a few months, then developing a business intelligence or balanced scorecard type dashboard, which looks at all the different aspects, will provide even more value. Whatever approach you take, the most important thing is that you have the right balance between the resource required, the burden you're placing on people and systems to collect the data, and the benefit you will obtain from the outputs which can be created. So, now that we've looked at the case studies, what are the takeaways we can get? So firstly, like pretty much everything in life, planning makes things easier. Think about the measurement and the evaluation early on. What will you measure and how will you measure it? And how will you collect the data in the most efficient manner? Knowing that something is going wrong is important, but potentially understanding why it's going wrong is so much more powerful. So ensure that there's a focus on qualitative aspects as well as quantitative to give you a richer picture and help you understand the nuances of your results. Finally, ensure that you consider a change management approach. Some aspects might get worse with the initial disruption. How much disruption is acceptable before the risk of compromising safety becomes too great? Are there any learnings you can capture to mitigate these risks in future with either a wider rollout or that you can take learn to different improvement projects? So now we'll round off this session and indeed our entire webinar series on the government's priorities. Let's look specifically at what does this mean for patient safety. So what began as the replacing of clinical commissioning groups with sustainability and transformation partnerships then spawned integrated care boards, which now have statutory responsibilities. One of these responsibilities is safety, and that means that there's very little national strategy and guidance because everything is supposed to be done at the local level. This is great insofar as it means that each ICB can focus on areas of greatest local importance, as was originally envisaged, but it also means there's no national mandate, no specific comparison, no simple way to triangulate what good or safe looks like. In secondary care, there's been a traditional culture of blame where root cause analysis was identified, so person X did thing Y, which caused Z. There's now the Patient Safety Incident Response Framework, or PSIRF, and that's aiming to change that paradigm by understanding that it's a different environment. It's the environment which facilitates or permits the actions. So rather than finding the person that did the thing that caused the issue, it's important to review why was that thing done, what can change systemically in order to mitigate a repeat of that risk. If it was implemented as envisaged, then PSIRF can drive improved safety and reduction in blame culture, but it can only go so far. The statutory responsibility of ICBs includes holding trusts to account for safety. So then that means that there's still the risk of underreporting of safety incidents. So how is all of this relevant to what we discussed today? Firstly, remember patient safety isn't always generic. Inequalities in healthcare create their own safety risks. It's well understood that diagnosis and treatment across men and women, across different ethnicities, across different levels of deprivation varies significantly. And as such, your measurement strategy will need to consider these wherever possible. Secondly, the technological revolution is very much on our doorstep with the era of artificial intelligence. There are, of course, big opportunities to improve safety in terms of technological innovation, but also significant risks. AI is a buzzword that's been around for a while now. We had the first machine learning decision trees, random forests. These are algorithms which can be deployed to improve diagnosis, treatment planning, disease prevention, and overall patient care by identifying patterns and trends that might not be readily apparent to humans. Now, similar to ChatGPT, there are a whole host of generative AI systems which can help with efficiency around administrative tasks. And these tools may just combine together to save the NHS as we know it, delivering the efficiencies which NHS England and successive governments have been craving. But is patient safety a key part of your implementation strategy? Can the machine learning algorithm account for the differences in skin colour or environmental factors? Can the Gen AI understand all the different accents and capture acronyms correctly? Collecting data on knowledge, awareness, acceptability, of course, that's all great. But what about patient safety? Safety data is often clinical. It can be complex and maybe hard to readily access. The tradition of underfunding of evaluation activities means that more difficult to measure pieces often get passed over and put into the too difficult category. The problem is, if there's no direction from the centre, and there's no regulation except at ICS level, then it's incumbent upon local systems to embed safety in all of their work, and technology should be no exception. Finally, we talked about the importance of qualitative analysis, but actually it's not about one method, it's about having a truly mixed methods approach to capture the different perspectives and to hold these up against clinical outcomes. Piece of technology that saves a few minutes in the short term, that's great. Does it do even more good in the long term? Might there be any long-term harms? For the most part, we don't know because the technology is so new, there is no longitudinal data. Now, that shouldn't limit you from exploring ways to generate your own evidence. Local systems need to develop their own patient safety culture, and measurement has to be a part of that culture. Maybe for now, the best we can do is to develop and embed roles and responsibilities within each local system and set clear expectations to ensure that patient safety remains at the heart of what the NHS does. And as Faye said at the start, all of this needs to be done in an environment of constrained budget. Now, we certainly don't have all the answers, but we would love to explore options with you. If you'd like to, then do get in touch.
Thanks, Ben. So that's the end of our workshop, but before we go on to the Q&A session, I just wanted to say that I hope you really enjoyed the workshop. As we mentioned earlier, this is the last in a series, so I just wanted to show you the full list of subjects that we've covered, and we'll send over a link to all of the previous workshop recordings, which we'll paste into the Q&A session. And these are our contacts, so you can access us on our website, Eventbrite, LinkedIn, or you can also book a one-to-one meeting in our team. So we'll put the links into the Q&A function.